So CAR T-cell therapy is a revolutionary therapy for multiple myeloma. Most certainly the landscape is changing. Originally, CAR T-cell therapies were approved in late lines and heavily pretreated relapsed refractory myeloma. Now we have KarMMa-3, we have CARTITUDE-4, essentially looking at patients being treated in earlier lines and compared to standard of care options. And now we do have approvals of CAR T-cell therapy in earlier lines. So we have ciltacabtagene autoleucel as early as second line of therapy in patients who are PI and IMiD exposed and lenalidomide refractory. And then as soon as third line, we have approvals both in the USA and in the EU of idacabtagene viclucel in third line and beyond for patients who are triple class exposed to an IMiD, PI, and CD38. So generally speaking, we also have other clinical trials looking at CAR T in the relapse setting with different targets beyond BCMA and BCMA, like anito-cel is coming down the pipeline. The data will be presented later this afternoon with longer follow-up. From what we've seen so far, the outcomes look great. You see deepening of those CR and stringent CRs, and there are no evidence of non-ICANS neurotoxicities or colitis, which is exciting. But we also have ongoing clinical trials in the frontline setting, right? We have CARTITUDE-5, we have CARTITUDE-6, and that might answer the question of transplant versus CAR T in the frontline setting. And then different targets, as I talked about, including arlacabtagene autoleucel, which is a GPRC5D targeted CAR T, which is also showing very excellent results even in the prior BCMA exposed patients. And we have other dual targeted CARs such as FastCAR, CD19 BCMA, and BCMA GPRC5D, and certainly preliminary outcomes look good, but we would need to look at safety and durability of response with those products. From a barrier standpoint, there are multiple considerations here. Manufacturing has significantly improved in terms of duration of manufacturing, scalability of manufacturing. We do have novel prognostic models, some to be presented at IMS, looking at what are the high risk factors for patients. We are doing more outpatient CAR T to help maximize resources such as hospital beds, and we are identifying prophylaxis strategies as well as patients who might be at increased risk of some of these non-ICANS neurotoxicities and prophylaxis strategies by looking at CAR T expansion and maximum ALC expansion between day 10 to 14 and different anti-inflammatory type of approaches. Certainly we have work to do. Manufacturing's improving. There's work in the in vivo CAR T space as well. But the field looks exciting. I guess I really would like to conclude by stating some CARTITUDE-1, right? The 5-year data looks extremely exciting. We see with the 5-year follow-up, 97 patients were infused. Of them, a third, or 33%, were alive and without evidence of disease progression. Truly impressive. If we think about the magnitude of these results, it's transformative treatment with potential curative benefit for multiple myeloma or functional cure, which very exciting time for us and for our patients.